Okay, good afternoon in the Central Time Zone of the United States. The SSRA is coming to you live. We're very excited to be putting on our first presentation today. We have Dr. Michael Levy with us. I'd like to just say a few words before we turn the presentation over to him. We have a real nice PowerPoint presentation and some talking points and some question and answer afterwards. Basically, I just wanted to talk about how the SSRA was formed. We're actually in our third year of existence. We were formed after a meeting at a rare disease conference in Washington, D.C. several years ago at the Every Life Foundation conference when I met Rory and Gary Daniel. Rory has since served as executive director, and together with Reese Holmes, they have formed a unique volunteer team to put this presentation on today. In partnership with our chief medical advisor, Dr. Michael Levy, the role of the SSRA is to be a coalition of people interested in raising awareness, fundraising, investigating medical research, and advocacy, and also to be a general clearinghouse of ideas and people that wish to further the cause of those who suffer from SS, superficial siderosis. Today, as I mentioned earlier, we were very excited to bring this live event, and we did do a live event instead of a recording, so please bear with us if there's a few technical difficulties. And also to present the third gift to Massachusetts General of at least $25,000. We made our initial commitment of $100,000 for 3 years ago, and now we have satisfied 75% of that goal, and we will hopefully continue to raise money for research and more awareness. Rory has also been working close with Dr. Michael Levy on grants, and we are hopeful one day to be awarded a research grant in conjunction with Dr. Levy and Massachusetts General. When that happens, we can be assured that someday we will find more treatment options for those who have superficial siderosis. As you watch today, you might be thinking, what can I do myself? Number one, volunteer your time or talents. Number two, raise awareness. 3, hold a fundraiser. 4, support a family member with superficial siderosis. Really, the list is endless. Also, we have an excellent website. Please make sure to check that frequently and sign up for email updates because periodically we do send those out. Thanks again. Enjoy the event. We'll have some question and answer at the end. At some point, I will change the background and I'll be able to show the check for $25,000 that we'll be sending out next week. Appreciate what everybody has done this year. I have so many people to thank that if I took the time right now, it would take up the rest of the presentation. So I'm just thanking everybody, but especially Rory Daniel and Reese Holmes today for putting on this event with Dr. Levy. Dr. Levy, the floor is now yours. Thank you.
Thank you, Kyle. And I just want to tell everyone how unique this is that in a disease state with so few people, probably less than 200 in the United States, that you could have such a vibrant and active advocacy group like the Superficial Siderosis Research Alliance. It is very unique. I've seen a lot of rare diseases, and it's hard to get this thing organized, and they've done a wonderful job. So they asked me to give you a year-end update, a kind of review of what's transpired, what kind of research has been done. And so I put together a short presentation, and then, as Kyle said, I'm happy to take questions afterwards. Can we go ahead and launch that presentation? On the next slide, I have the 3 focus areas that I thought I would update everybody on, and that's awareness, basic research, and treatment. So let's start with awareness on the next slide. First, what does awareness do? Well, in other words, why would you want to make others aware of superficial siderosis? And the reason is that it improves funding for research. if people understand that this is a need and that we need to improve on treatments, then it paves the way for research funding. When institutes like the National Institutes of Health, for example, they want to decide where they're going to budget their money, if they don't understand that there's a need in superficial siderosis, then they won't be interested in funding it. But if they do understand there's a need and that there's awareness out there and that people are raising awareness so that people can understand that work needs to be done, then that does help us out a lot. What else does awareness do? Well, it also piques the interest for other researchers. So, for example, if there are people out there who have a peripheral interest in superficial siderosis, then what that does is, it opens up potential collaborations. People might have other ideas. And thirdly, what the other thing that awareness does is that it supports industry development. So when companies look to decide where they're going to invest and they have a potential drug that may help superficial siderosis, they want to know that there's a group out there, an effort that can help recruit patients and so on. And so that's why awareness is so important. So what have we done in awareness? On the next slide, you'll see that, well, first of all, we have the Superficial Siderosis Research Alliance. That's key. I mean, just having that wonderful website with all the knowledge base there and opportunities to connect and the newsletters that you get is really important. Then there are other Facebook groups like Silent Bleed and others where people can connect through social media that's available worldwide. I think that that's critical. And lastly, through academics, we've raised awareness. First of all, there's a group at the Massachusetts General Hospital where I practice that's interested in amyloid angiopathy, which is a different type of vascular disease in the brain. But as a result of that disease, they also have iron deposits. And so they're looking for ways to remove them. And of course, we have many years of experience doing that in superficial siderosis. So I presented to this group and we established a collaboration. And the reason that's important is because amyloid angiopathy is more common. There's more funding for it. And they have researchers in areas like radiology that can help us as well as helping them. And then lastly, I did present on the superficial siderosis topic at a grand rounds for neurology for the Department of Neurology at the University of Utah. They asked me specifically to address this topic as they had a number of cases in Salt Lake City. And I would say that there was widespread interest, not just in the disease, but in the mechanism of action, the science that underlies it. And I got a very nice response there. Okay, on the next slide, I wanted to update you on the basic research that we've been doing. We're really trying to answer 3 questions. The first is, what is the underlying damage that's done? When we have the opportunity to look at a piece of tissue from a superficial siderosis patient, we can actually see where the damage is. Is it damage to blood vessels? Is it damage to the cells? Is it damage? If it's damage to cells, which cells are being affected? Is it the neurons? Is it the supportive cells? Is it the myelin producing cells? Is it immune cells? Like, what's the actual pathological damage? And then the next question is, can brain tissue be protected? There are many efforts across several diseases, neurodegenerative diseases, to try to protect the brain. Now, there are many different diseases, many different neurodegenerative diseases, and they all have different pathogenic mechanisms, but ultimately what they're all trying to do is protect the tissue from any sort of destruction. And so we're trying to learn from those diseases and see if we can apply some of those neuroprotective strategies to superficial siderosis. And then lastly is damaged circuits. So in superficial siderosis, there is damage that's done. And even if we're able to remove the iron and prevent any further damage, we're still trying to find ways to restore those damaged circuits so that you can recover function, so that you can hear better, walk better, and feel better. So on the next slide is the gross pathology study that my colleague Arnie Koppen published over 10 years ago now. What is it? Oh my gosh, 13 years ago. Arnie is a pathologist who has spent 50 years at the University of Pittsburgh collecting pathology samples. And he has about 9 already. And here's an example of one, just to show you what this looks like. A lot of patients have asked me, what does the actual brain tissue look like with iron coating? What does it look like? Well, this is what it looks like. This is the back of the brain called the cerebellum. And it has many of those folds. You can see those folds. And what happens is the blood products are getting trapped inside of those folds. And so, because it's an iron-based compound, these are iron deposits, they have this reddish hue. So normally, if you see the edge of that cerebellum there, normally with this type of fixative, the brain tissue looks that pale yellow, but those brown areas, those brown reddish areas, that's what the iron deposits look like. It's a really thin film, okay? It's not like this thick plasticky coating. It's really just a thin film of iron deposits that coats all the different folds of the brain. In panel B, what Arnie's shown is that there's only one cranial nerve that is really affected. Cranial nerves are nerves that come directly off the brain that go to the face usually. In the case of cranial nerve 8, you can see that V111, that's cranial nerve 8. That's the only nerve that spends any time in the spinal fluid where the blood products are. And that's why it's coated. You can see it's relatively orange. As opposed to cranial nerve 7, right next to it, you can see that that's much lighter in color because that nerve doesn't spend much time in the spinal fluid and is not as vulnerable to the iron deposits as cranial nerve 8. Cranial nerve 8 goes to the ear and is responsible for hearing and for balance. Cranial nerve 7 provides motor function to the face. So that's why your facial strength is preserved. You can smile, you can blink, you can do all the things you need to do with your face, but your hearing is compromised because it's that specific nerve, the one that spends a lot of time in the spinal fluid, that's particularly impacted. So we have this gross pathology from about 9 people. And I know that you've probably heard we have a calling for people to donate brains at the time that people pass away. We would love to harvest the brain and to take a look and see what does it look like, especially after you use Ferroprox. This slide here with the microscopic images, what this shows us is what the damage looks like in at least this one patient. And what it shows on the left is actual loss of tissue. So there should be a lot more red and blue in that area. And the tissue that's thought to be lost are supportive cells and nerve cells. And on the right, you could see those green areas where the arrows are pointing to. That's iron deposits that are trapped within the supportive cells. Those supportive cells are trying to take up and buffer that iron, but eventually they become overwhelmed and they start secreting a protein to stick to the iron. And when that product floats around the spinal fluid, it precipitates out and attaches to the surface of the brain. And every once in a while, that iron molecule can then cause damage to the underlying brain tissue. So that's what we can see in these few slides. And as I said, we do have a new study where we are requesting new brain tissue so that we can investigate new ideas, see if this pathology is consistent throughout, and also, really importantly, we want to see what happens after Feraprox use to see if we've made any difference in the tissue loss and the recovery after Feraprox. So on the next slide is a diagram of what kind of information we can gather from pathology and what kind of science we can propose. So for example, in this slide here, you could see that heme, which is the iron carrying compound in red blood cells that gets released after a bleed, in combination with oxygen and other molecules, forms biliverdin along with carbon monoxide and free iron. And this product that makes that free iron, that is the toxic compound, is that Fe2+. That Fe2+ is damaging, and we want to avoid that from happening. So one of the ideas on the next slide is to use a compound called tin protoporphyrin, which blocks the enzyme that allows that free iron molecule to come out of the heme molecule. So heme oxygenase is an enzyme, and it takes oxygen in heme and that NADPH down there, and it produces the biliverdin plus the free iron. And if you block heme oxygenase with this tin protoporphyrin, you can actually prevent the free iron molecule from developing. And this has been demonstrated in rabbits, for example. Now, it's not that obvious what would happen if we don't allow this process to take place. You see, the brain wants to break down heme because it wants to recycle the iron and get rid of it. But in the case of superficial siderosis, where there's just too much heme, we don't want to make all that iron. We don't want to make all that free iron and cause all that toxicity. But we don't really know what would happen if we block that conversion process. Would that just build up a lot of heme? Would it eventually break down into some other toxic molecule? We're not quite sure, but that's the type of research that we can do in animal models and answer those types of questions. On the next slide, I just want to update you on what we're doing as far as treatments go. Feraprox or deferriprone is still the only available chelator of iron that can get into the brain. So the molecule deferriprone is an iron chelator, and there are 4 other iron chelators on the market in the United States, but none of them get across into the brain. The brain is a very protected organ, and not many things that you consume, either food or molecules or minerals or medications, gets into the brain. But deferriprone does, which is why we started looking into it way back in, 2012 now, when we first started looking into it. And in 2012 was when we first proposed to start using it in superficial siderosis. At that time, the drug was not approved in the United States, and the FDA only let us use it for 3 months in 10 people. And it proved to be safe, which is really what we were trying to prove to the FDA. Eventually, the drug was approved, and now we've been using it pretty regularly. It's not approved for superficial siderosis per se. It's approved for other iron overload diseases, but since it's approved for a disease in the United States, then at least we can still use it, assuming insurance will cover it, which is a major problem because it's very expensive. Since it was approved, we've been able to do a study with 38 people who have superficial siderosis, and we treated them for 2 years each. And what we looked at was MRIs and any clinical improvement. So this video shows is how we developed a method to quantify iron by MRI. It shows an MRI picture here. You can see the green area around it. It's a very rough measure of the brain. And all we're doing is we're telling the computer what to measure. And as soon as we draw that green region of interest, the computer then tightens it up, takes it right from the black skull area, captures the entire brain in a three-dimensional figure. And then we can ask it to quantify all of the iron relative to the spinal fluid signal. And on the next slide, you can see what that data looks like in table 4. So in table 4, we managed to get 16 out of the 38 patients to get an MRI before and after on the same machine with all the same parameters so that we could really compare apples to apples. And when we did that, you can see in those next columns there, we were able to quantify the total amount of iron and compare it. Look at this MRI, for example, where I admit the arrow is very small, but the arrow is pointing to that black area right in the middle of the cerebellum. That's an iron deposit there. And if you look at the right-hand side, that's what that same area looks like after 2 years of deferriprone. You can see it looks a lot lighter. Now we're able to quantify that using a computer at every level of the brain. And what we found is that if you look at that table again, out of those 16, there were 2 people who had improvement on clinical function, either hearing or balance, and both of them were associated with a decrease in iron deposits. Then there were 4 people who, despite deferriprone, continued to accumulate iron by MRI. And it seemed to be getting worse, even though they were on deferriprone. And then the other 10 people seemed to be stable clinically. And you can see on their MRI changes, some of them had a little bit more iron and some of them had a little bit less iron. Now, this was just a 2-year study, but one of the things that really encouraged us was that 10 out of the 16 people had a stable clinical exam, stable hearing, stable mobility. And that's really important to us because even if we can't reverse things, even if we can't help you recover from the damage that was done, at least what we could do is try to keep things stable. Okay, on the next slide, I'm listing here alternatives that we're considering, things that we've tested and things that we have not yet tested. A lot of people have tried different iron chelators at different times, and none of them seem to work unless they get in the brain. That seems obvious. And so far, deferriprone is the only one that does that. One of the very intriguing untested ideas that Rory and I have come up with is a trial for inositol hexaphosphate. Inositol is the backbone of all amino acids, and hexaphosphate just means that there are 6 phosphate molecules that are attached to this inositol molecule. And those hexaphosphate molecules help to chelate iron. And inositol itself is a molecule that helps prevent damage to the brain. It's a neuroprotective agent. It's been tested in Parkinson's disease and it seems to work in Parkinson's. And we're hoping that it works in superficial siderosis. Now, if you're my patient, you've probably heard me talking about it. I talk about it even though we don't have data for its use because it seems to be extremely safe. And it's something that I've been recommending to people and can be used even in combination with deferriprone, but we don't yet have data on it. And so one of the research proposals is to test the benefit of inositol hexaphosphate. Vitamin C is an intriguing vitamin. It's widely consumed in food and in multivitamins. But vitamin C is very potent for people who have iron overload. It helps to shake loose the iron from the ferritin molecule that's holding it, and it helps to then chelate that iron molecule. So vitamin C is something that we've also been playing around with. If you're my patient, maybe some of you are on vitamin C, we're trying to see if it's helpful or not in expediting. In other words, I'm trying to get rid of the iron faster. So lastly, I just want to sum up focus areas in superficial siderosis that we're looking forward to in 2022, in the coming year. On the area of awareness, I can't thank the Superficial Siderosis Research Association enough for putting on events like this that help spread awareness. On the basic research side, the SSRA is supporting us in a research grant proposal to the NIH for a lot of money. And we're hoping that they support a natural history study in superficial siderosis, which helps to understand what the normal disease course looks like so that we can understand what impact potential treatments might have. And those treatments, we're continuing to use deferiprone, but we're also hoping to find other means and other ways of expediting. I have patients who've been on deferiprone for many years, and eventually the MRIs show clearing of the iron. It could take frustratingly long times, 5 to 10 years, and we want to try to find means of expediting that chelation process. So those are the plans for 2022, and I'm happy to take questions and answers, and I'm going to turn this back over to Kyle, Reese, and Rory.
The first question I've got is, what is known about the way SS affects the gut, intestine, and bowel, and how can that be treated?
That is an important question. What we know about superficial siderosis is that it remains confined to the central nervous system. So it doesn't attack the gut per se. You're not going to find any iron there. But the gut is controlled by the spinal cord. And there are nerves that come out of the bottom of the spinal cord that go to the gut and help it move along. Now, if you were to sever those nerves completely, there would still be a regular process to move things along in your gut, but it wouldn't be timed and controlled. It would really just be the gut has its own internal mechanism that would take over, but it's not reliable. It doesn't respond to food or to day-night cycles or things like that require neurological input. So there is some control that may be lost if the iron deposits are affecting those nerves at the bottom of the spinal cord.
Okay, so I think the question is there anything you could recommend that would help that?
With the gut, it depends on the issue, for example, if there's slowed motility, in other words, if things are going slowly through the gut, you may need stimulants to help things move faster, or you may benefit from stool softeners. There are also laxatives and suppositories that'll help. On the other hand, if there are problems where things move too fast, you might need to slow things down with bulking agents like Metamucil. If you're having bloating and pain, there are ways to deal with that. So it really just depends on what the problem is, but mostly the target is to try to find a symptomatic treatment. You're not going to fix necessarily the nerve problem unless you're using chelation therapy and hoping that the damage heals over time. What you really want to do in the meantime is try to find strategies that all the GI doctors use for any gut issue, so laxatives and so on.
Okay, thanks, Dr. Levy. I'll go on to the next question. Okay, someone's asked that the relative who's got superficial siderosis has contracted COVID and has become very weak, and asking if the COVID could be causing the weakness or making the SS worse, or both.
That's hard to tell. COVID doesn't tend to cause weakness per se. It can cause extreme fatigue and loss of energy, but weakness is something that superficial siderosis can cause. It just depends on how severe the siderosis was. So only knowing that he has a combination of superficial siderosis and COVID, I wouldn't know how much to ascribe to each one individually, but I would say that the siderosis can certainly be a predisposition for a bad outcome in COVID, right? We know bad outcomes in COVID are related to age and other comorbidities. I would think that a severe case of superficial siderosis would be one of those comorbidities. And if I had access to that patient and I could get that person aggressive treatment for the COVID, I would. Like monoclonals, for example.
Okay, thanks, Dr. Levy. The next question we have is, with CSS, someone has in one location, is it possible to get it in more locations or for it to increase?
It depends on what caused it. So CSS is cortical superficial siderosis. It means that there's one spot in one area of the brain. And as opposed to superficial siderosis, the idiopathic type that a lot of people have, which is where the bleeding happens in the spinal fluid and it ends up coating many different parts of the brain. Cortical superficial siderosis, if it happens by itself, is generally harmless because involving one part of the brain, it doesn't have as much of an impact as involving many other parts of the brain. And that one part of the brain can compensate. So it can find strategies to reroute circuits, for example, over time. Now, if you have one, you have to ask, well, why did I get that one? Am I going to get more? There are diseases like amyloid angiopathy, which is an unrelated disease that causes superficial siderosis and starts that way. So if that's the basis of your cortical superficial siderosis, yes, it is expected to worsen. However, some people have cortical superficial siderosis from a single surgery. That's not going to happen again, or a single injury. Hopefully that won't happen again, like a trauma, something like that. So then it would not be expected to recur or to expand.
I think you've just answered the next question, which was, what's the link between CAA and CAS?
So there is a link between CAA, cortical or cerebral amyloid angiopathy, and cortical superficial siderosis. So that's where amyloid angiopathy is a disease of the blood vessels, and they can rupture. And if it ruptures enough, it'll form a superficial siderosis looking lesion on the surface of the brain. It is a sign, if you have superficial siderosis from cerebral amyloid angiopathy, it is considered a bad prognostic sign. It is dangerous, and it does warrant really aggressive therapy for the amyloid disease to prevent that from getting worse.
Okay, so now, does Gilbert syndrome have any connection because of bilirubin related to the liver?
So Gilbert's disease is it's a metabolic condition in which the breakdown of blood products is compromised, and it's a liver issue. And so when you normally recycle your blood cells, the liver is responsible for a lot of that turnover. Since this person has Gilbert, I don't know that there's any link with superficial siderosis. I'd have to think through it a little bit more, but it doesn't necessarily ring a bell to me. They're both related to blood breakdown products, yes, but one's in the liver and one is in the brain. I'd have to think whether or not there may be a connection.
We've got, is Inositol hexphosphate available? What's the dosage that's recommended?
Inositol hexaphosphate, or Ip6, is available over the counter. You can buy it on Amazon. You could buy it in your local. I don't know if it's widely available in like every pharmacy, but it's certainly available online. It's inexpensive, relatively inexpensive, and depending on the formulation, I would just follow the recommendation on the bottle. So some of them will be 50 milligrams and some will be 100 milligrams or more, but it just depends on how they formulate it, and you can just follow the instructions on the bottle.
I think if someone's asked a question from what you were mentioning earlier, what doses of vitamin C are you trying? I think that's in relation to helping the
vitamin C dosage that we're trialing is considered mega doses. So we use 2 grams or 2,000 milligrams. But we know that the vitamin C can bind to the ferroprox. So you can't give them at the same time because they'll stick to each other in the stomach and then you lose both of them. And so we have to time it. Give the deferriprone in the morning, vitamin C at lunch, and deferriprone in the evening, and then that allows the absorption to take place, and hopefully for the interaction of deferriprone and vitamin C to take place at the location of the iron molecule, because that's where we want the interaction to take place, not in the gut. So we are using a 2-gram dose. It's the same that if you had an iron overload disease of the heart or of the liver, for example, that's the type of dosage they were to use as well.
Does superficial siderosis shorten life expectancy?
We don't know the answer to that. I have not, it's not an obvious shortening if there is. Most of my patients are in their 60s and 70s, and I have had 4 patients who've had strokes. They were all in their 70s and 80s at the time. And so I don't know if they didn't have superficial siderosis, could they have lived longer? That's possible. And I don't know if the superficial siderosis was a predisposition for the strokes. I don't know the answer to that. If there is a shortening of the lifespan, it's not an obvious yes. It might be a subtle difference.
Got someone else that says someone's lost this sight due to superficial siderosis. Why is that less common than any of the other symptoms?
The optic nerves are surrounded by spinal fluid, and they are vulnerable to superficial siderosis, but they're huge relative to the other nerves. And so the surface area to volume ratio does not make them particularly vulnerable. Most of my patients do not have difficulty with vision, and the eyes themselves are not in contact with the spinal fluid and should not be involved. So the other part of the vision area that can be involved is the back of the brain. So your eyes take in the light, but your brain actually sees the object, and that all occurs in the back of the brain. And I suppose that can be involved to a degree that you can become what's called cortically blind. So that's where your eyes are functioning perfectly fine, but your brain can't see what your eyes are telling it. I don't know if I've rarely ever seen cases like that. It's usually due to severe damage in the back of that brain, like from a huge stroke or something like that, not from superficial siderosis. So my first inclination would be that if you're young with superficial siderosis, I'd look for other causes. I wouldn't immediately blame the superficial siderosis. I'd want to look for other causes of vision loss.
Someone said they've just been diagnosed with superficial siderosis. Should they push quickly to get an appointment with a neurologist?
Yes, of course, but I would reassure you by saying there are very, very few emergencies in superficial siderosis. The progression of the condition tends to be very slow. The recovery tends to be very slow, unfortunately. And pretty much the only thing that I've ever seen that's a real emergency is related to side effect of the ferroprox that can affect the immune system. That's pretty much the only real emergency that I've seen. Everything else is just very slow and progressive, and there are no real urgent issues, once you start the Faraprox, it's kind of anticlimactic. Nothing goes fast, everything goes slow. But yes, of course, once you have your diagnosis, you need answers to all your questions, and you get those best from your neurologist.
That's great, thank you. Alpha, I think, sorry, this is from Rory, I'm just reading that. Alpha Lipoic, is that right?
Alpha lipoic acid, okay. Alpha lipoic acid is a supplement that's been trialed in other conditions, other neurodegenerative conditions, for things like unsteadiness and imbalance, and it's essentially harmless. I've really never seen any condition to worsen with alpha lipoic acid. It is also available over the counter for an relatively inexpensive cost for a supplement. Since it's essentially harmless, I have no problem with it. I just don't have the data that it's effective.
So is another person, John, has asked, how can he decrease nerve pain in the back and the spine?
Nerve pain in the back can be due to a number of different conditions, including surgeries or the defect that's causing the bleeding in superficial siderosis. It can also be due to muscle spasms. It really depends on the cause of the pain. And so one of the things I recommend, there are things you could do for all kinds of pain. For example, stretching and exercise to maintain as much function and flexibility as you can. But beyond that, the next big question is this a muscle pain that can be relieved with heat or massage, or is it a nerve pain that may require a medication or a lidocaine patch, or even a TENS unit, transcutaneous electric nerve stimulation, that that deprioritizes pain signals in the back? So it really depends on what kind of pain you have in your back, and that's something that your neurologist can help sort out.
Okay, how can patients with comorbid diagnosis like autoimmune issues be helped?
You know, everybody has comorbid issues. As I said, most of my patients are in their 60s and 70s. And by that age, there's all kinds of other things going on, prostate issues, blood pressure, in your case, autoimmunity. And it's just something in addition to manage. And we want to try to improve quality of life, so we don't want to make your life too miserable. We want to try to balance any sort of treatment with impact on quality of life. And so, you know, it's not unusual, I would say, that superficial siderosis patients have comorbid issues. But they're all manageable, hopefully.
Thank you very much. Is superficial siderosis genetic or hereditary condition?
Probably there might be a component that's genetic. What I mean by that is that everybody has a different way of reacting to the iron molecules if you bleed in the spinal fluid. And that's controlled by your genetics. So which proteins you produce, how much you produce, how well those proteins protect against the iron molecules, how vulnerable the brain is to the freed iron molecules, that's all genetically controlled. The cause of the bleed is not genetically controlled. So most cases are due to trauma or surgery and poor healing. And that's just something that's outside of the genetic control. So there are genetic inputs, but they're not the basis of the condition, if that makes sense.
Thank you very much. Someone else has asked, if they're not taking deferriprone, could they take a combination of Ip6 and vitamin C to help?
You know, I think so. I don't have the data for that yet. That's something that the SSRA and I have been planning to do, is a trial with Ip6 plus minus vitamin C even, to see if that's helpful. And while we don't have the data, I do encourage people to use it because it does not interact, it doesn't interfere with anything we're doing, and if anything, it could just be helpful. As far as we know, it's not toxic. So I have been recommending it.
Thank you very much. Are there any specific requirements for harvesting the brain?
A gruesome question, but it's an important one, and there is an important requirement. At least in the United States, the requirement is that when you die, your next of kin gets possession of your body. You have no more control. So you can't request that your brain be donated to science. Your next of kin has to do that, because as long as you're alive, you can't donate your brain, and then as soon as you die, you have no more control of your brain. So do be sure to tell your family members what you want to happen with your brain. And that is the best way to make sure that it happens. There is a cost. So when the brain gets removed, there is a pathologist involved in doing that and the shipment, and it can cost up to $1,000 in some cases. Insurance might cover it, especially given the disease diagnosis, so you have to check on that. And we do have a sign-up list on the Superficial Siderosis Research Alliance website for people who live in the United States. This is something that we might be able to help you with, but it is very individualized, and it matters where you pass away, and which hospital you pass away, and in which state you pass away, and whether they have a pathologist on call. So all these things matter.
Okay, someone else has asked, is there a set period for Therabox treatment?
It takes a long time. So we'll use it for as long as it takes to get rid of the iron, which could be years in many cases. Just depends on how much iron there is to begin with. But in many cases, it takes 2, 3, 4, 5, 10 years in some cases to get rid of the iron. And then it also depends on whether you're continuing to bleed. If you are, the Theraprox is very good at getting rid of the new blood iron deposits. So it just depends on every individual.
With CSS, does ringing in the ears or tinnitus stop, or is it persistent?
So cortical superficial siderosis would not be expected to cause ringing in the ears. Okay, but if you have cortical superficial siderosis and ringing in the ears, then one implication might be that the bleeding is beyond that cortical strip, is getting into the spinal fluid, and is then involving those nerves going to the ears. And so that might be causing the ringing in your ears, is bleeding beyond that cortical strip. And in that case, when does the ringing stop? You might have to remove the iron, okay, to get rid of that. But once all of the iron is gone, we don't yet know how much healing can take place. That might depend on how old you are and what your individual healing capacity is. And so a lot is dependent on individual parameters in your case.
And someone else has said, how persistent should they be at trying to find the location of the bleed and to stop it?
It depends. You know, there are many people whose bleed is inaccessible. It might be in the spinal column right behind the heart, and no surgeon can get there safely. And so in that case, it's not worth going for, because there'll be more damage done trying to stop the bleed than the benefit from stopping the bleed. So it really just depends on every individual's case. If your bleed is very accessible, then I would say, you know, go for it. And it also depends on whether you're getting a lot of headaches, which is a result of acute bleed. So every time you bleed and you get a headache, if that's the case for you, then it might make sense to go for the bleed so that the headaches stop. But as far as getting rid of the iron, it does help to stop the bleed, and hopefully it'll shorten the time that it takes to get rid of all the iron.
Okay, so someone's asked, what does the end stage for SS look like?
Haven't had a lot of end stage SS per se. I've had very older folks with superficial siderosis, and they have the typical older folks things going on. I've had 2 patients with Alzheimer's. I've had a patient with Parkinson's disease. I've had a patient with strokes, 4 patients with strokes. So these are all happening, and we don't know how superficial siderosis is impacting on those disease processes, but they do occur in addition to the superficial siderosis. And you know, if you let superficials go untreated for a long time, mostly you get deafness, and you get severe imbalance, and then bladder dysfunction. Those are probably the top 3 things that I see in the sort of end stage with decades of untreated superficial siderosis.
Okay, thank you. There's one question left on here now. I'm just going to try and word it out, and then we can wrap up then if that's it's okay. That's the last one that's on the list. Someone's asking, they've got superficial siderosis, but it looks like they can't find the leak. Should they have an MRI to try and look for a leak?
You know, MRIs are pretty good at finding leaks, but it's not perfect. There's a CT angiogram, which is even higher resolution, but that's a little bit invasive. It involves placing a needle in the lower back, and so it is invasive and has some risk, and so you shouldn't just rush to get it. You should balance those risks to make a good informed decision with your neurologist. But an MRI is pretty harmless and can always be done if there's a question about whether there's a persistent leak or whether the healing is getting better. I usually get MRIs in the brain every 2 years for Faraprox patients just to monitor the progress of the chelation. In the spinal cord, though, it's not as helpful because the spinal cord doesn't have as high resolution as the brain.
There's a little bit more on the end of that. They said, if not treated with deferoprone, will the deposits lessen or will they remain the same?
Most of the time, the deposits will just remain there. The brain has a limited capacity to remove iron. The spinal cord has even less capacity to remove iron. It really depends on the amount and the extent. A little bit it can do. A single bleed from trauma is fine. 2 bleeds is fine. We've evolved with the ability to get rid of blood in our brains if it happens once or twice or 3 times. But a repetitive process happens over and over again, simply overwhelms the system. And then it becomes very difficult to remove the iron.
That's brilliant. Thank you very much for answering those questions, Dr. Levy. That was the last one. I believe Kyle's going to wrap up now, so I'll over to Rory to sort that out.
All right, thank you very much. That was very informative, and we thank you, Dr. Levy, for your time today. I'm just going to leave our presentation today with the check presentation. And we will be sending this out, like I said, next week, our 3rd installment of $25,000 to Dr. Levy and Massachusetts General. Thank you for all everyone is doing. Make sure to check out the website, like Reese mentioned earlier. We have a ton of information on the website, and anything you do, if you want an update, you can sign up for the email updates. With that, we're going to conclude the meeting. Thanks, Reese and Rory, for all the hard work in the background to get this together.
Bye, everybody.
Thank you. Thank you for all the donations, people, everybody. Thank you so much.